Okay, I'm going to show you guys an alternative treatment technique and position in order to engage the pubofemoral ligamentous tissues with your patients. Now, typically with the pubofemoral ligamentous tissue, we're going to have our patient lying supine. We're going to take the hip and the femoral acetabular capsule to where it's in a 50 degree of abduction or abduction in order to engage that tissue. But if you've got a patient that's already in a prone position, here is a nice, easy way that you can engage the pubofemoral ligamentous tissue while they're in this position. So one way is to actually take their knee. Now make sure that they don't have any issues with their knees. You have to ask questions about if they have any conditions or injuries or any type of surgeries, if they've had a total knee replacement or partial knee replacement. You're going to want to know that in their history. Now with the patient in a prone position, remember that for the pubofemoral ligamentous tissue, we need to get them into 50 degrees of abduction or abduction. So you're going to have to take the leg out into abduction off to the side, and you're going to see if you can get their knee just to relax nice and gently in this position. Now, you can see that we've taken the leg into 50 degrees abduction. We're engaging the pubofemoral ligamentous tissue in through the anterior aspect of that femoral acetabular capsule. And what we're going to do is take our hands again onto the posterior aspect of the head of the femur, and we're going to load the tissue into the table. So we're going to try and take this head of the femur and we're going to load it anteriorly. We're going to translate it anteriorly because we want to recreate a proper force coupling mechanism in through that femoral acetabular joint capsule. And if pubofemoral ligamentous tissue and the other soft tissues that it works in series with are causing that dysfunction, this is a great, easy way to work with those tissues, engage the pubofemoral ligamentous tissue, direct the head of the femur in an anterior direction right into the table. And again, we're going to sit and wait for a decrease in densification, an increase in elasticity. We're working with the reciprocal tension of the tissues. If you, again, load in too much, too soon, too fast all at once, your patient is going to respond with a protection guarding mechanism in through the anterior joint capsule, through the musculature and the soft tissues that run in series with that tissue, and it's going to be detrimental to your treatment. So just take it nice and slow, respect the reciprocal tension of the tissue, and when you get to the point where you've got a nice elasticity through the tissue, there's a decrease in densification, and there's a decrease in protective guarding mechanism with the patient, then you can slowly take your hand off of the posterior aspect of the femur. If you take it off too quick, you're going to get an actual re-engagement of the tissues, a protective mechanism, and we don't want that. So be really kind to your patients. Slowly take your hand off of the posterior aspect of the head of the femur, and you can slowly bring the knee back into place. Another way that you can engage with the pubofemoral ligamentous tissue is similar to the iliofemoral, where we had 20 degrees of extension happening. When you take the femoral acetabular joint capsule into 20 degrees of extension, and then you also add in external rotation, now you're getting the pubofemoral ligamentous tissue again from the prone position. So again, you can either start with them with the hip in neutral position, taking the leg into abduction 50 degrees, or you can, if you've already worked with iliofemoral ligamentous tissue like we did in the previous video, and you want to incorporate pubofemoral at the same time, all you do is you take the leg out into 50 degrees of abduction, make sure that you're keeping the knee at a nice 90 degrees, be careful of any knee issues, load again the head of the femur anteriorly. You're going to anteriorly translate the head of the femur in that acetabulum to engage the pubofemoral ligamentous tissue, work with the reciprocal tension. When you get an increase in elasticity, a decrease in densification of the tissue, slowly take your hand out, take the leg back to neutral, put the knee back on the table, and put the leg back in place. And that is an alternate treatment technique for working with pubofemoral ligamentous tissue. So let's see what that looks like with our patient on the table. An alternative position for working with the pubofemoral ligamentous tissue of the femoral acetabular joint capsule is to have your patient lying in a prone position. Now again, you need to be aware of if they have any issues with their knees where this position may be uncomfortable because of conditions or injuries to the knee. This would not be an appropriate technique to utilize for the hip. Or if they have a lot of complaints, comments, or injuries to the lumbar spine where this increases their sensitization to the nervous system through the lumbar spine. If that's happening, this is not an appropriate technique for that either. But if the lumbar spine is clear and the knee is clear and we want to access the pubofemoral ligamentous tissue of the femoral acetabular joint capsule of the hip, we know that we need to get the hip into 50 degrees of abduction. So what we're going to do is just gently take the leg out to 50 degrees of abduction, and we're also going to just allow it just to comfortably sit where its length allows it to. I'm going to slowly come up to the posterior aspect of the head of the femur with my outside hand. My inside hand is going to again reinforce at the posterior aspect of the head of the femur, and I'm going to load that head anteriorly into the table. So it's a direct posterior to anterior compression into that femoral acetabular joint capsule. Again, we're not just engaging the pubofemoral ligamentous tissue, but we're engaging any musculature that runs in series with that tissue. So that would be iliacus, psoas, and the adductors that cross the same joint. If you find that the foot starts to come up, you can sustain the hold with one leg, and you can slowly, providing that there's no issues with the knee, you can slowly take their foot back down and get a little bit more of an engagement in that tissue. If you find that the quadriceps are a little tight and are causing an issue, then you can back the angle off and you can get more engagement of that tissue anteriorly into that pubofemoral ligamentous capsular tissue. So with this technique, again, we're looking to reestablish some elasticity, decrease some hypertonicity and guarding, decrease some densification through the tissue, and encourage that femoral acetabular joint to have a proper force coupling mechanism. The head of the femur should be drawn anteriorly in this position, and we're just sort of enabling it and helping it get to that point. So we would hold this position until those tissues soften up, and this permitted motion allows us to get here. Come back out, load back in again, and we've got a lot more elasticity in through that pubofemoral ligamentous tissue and through the musculature and soft tissue that cross that joint, working in series with that pubofemoral ligamentous tissue. Once that's completed, slowly bring the leg back to neutral, and that completes the technique for the pubofemoral ligamentous tissue in the prone position.